We Can Lead Change, a neighbor-to-neighbor grassroots organization in the Fox Valley, was founded in 2017 by Mary O'Connor after the Women's March. We have sponsored educational forums and organized local women's marches in both 2019 and 2020. Our September presentation was on voting by mail in Kane County. The opportunity to talk about kitchen table issues and learn from our neighbors is the foundation of the We Can Lead Change educational series. We are committed to bringing civic-minded issues to our community because the ideas surrounding human decency and acceptance of one another shouldn't trigger fear or be considered radical. We have the broad mission of preserving and protecting democracy, and we believe every citizen should have equal access to voting. This past spring and summer, when our country's long struggle with racism erupted under the spotlight of the Black Lives Matter movement, We Can Lead Change decided to focus our educational series on racial justice. From listening to Black community members in the Fox Valley about their experiences, frankly stated and earnestly shared, we realized the need to further understand and contribute to the education about everyday racial bias, what Black neighbors in our community have known their entire lives. We know the importance of electing public servants to reflect the diversity of our community. We encourage you to join us in this pursuit. Please follow us on social media, get involved, and learn with us as we commit to examining and better understanding systemic racism while working to find ways to advance anti-racism at the local level. We Can Lead Change reached out to every Kane County candidate running for public office in the 2020 election with an anti-racism questionnaire, asking leaders from both parties to submit their answers with the goal of sharing their policies on diversity and race. The candidates' responses to racial justice questions are posted on the We Can Lead Change website. For one group of people to be disadvantaged, there must also be a group that is advantaged. Health equality is an umbrella issue for all aspects of racial justice, whether it's criminal justice reform, education, employment, environmental justice, gun violence, affordable housing, immigration, mental health, or police reform. Access to affordable, quality health care affects the experiences of Black people and people of color differently than for whites. Our zip code determines our health to a measurable extent, and racism has played a significant role in the creation of America's healthcare system. As the pandemic illustrates, all policy is health policy. In order to protect our health, we must protect our health care. Who we elect to serve at every level of government affects whether or not everyone has equal access to health care. We Can Lead Change stands firm in our resolution that electing candidates who support equality for all is integral to the change we seek. In 2018, we worked on campaigns to elect Lauren Underwood, Sean Casten, Karina Villa, and more. Congresswoman Lauren Underwood and members of the Black Maternal Health Caucus introduced the Black Maternal Health Momnibus Act of 2020 to fill gaps currently contributing to the Black maternal health crisis in America. Congressman Sean Casten has co-sponsored the Medicare Negotiation and Competitive Licensing Act that would directly allow Medicare to negotiate the price taxpayers pay for prescription drugs. Tonight, we have partnered with Illinois Single Payer Coalition for a presentation on health justice and racial inequities in healthcare. Our presenters are KATHRYN and Dr. WINNIE Lin. KATHRYN currently works as a community health nurse on the south and southwest sides of Chicago with a particular interest in chronic disease education and management. KATHRYN advocates every day for clients within our overly complex and inequitable healthcare system. Dr. WINNIE Lin is a primary care pediatrician at Miles Square Health Center, a federally qualified health center on the south side of Chicago. Dr. Lin teaches pediatric residents and medical students at the University of Chicago. I will now turn the discussion over to our facilitator, Jordan Centers from Illinois Single Payer Coalition.
Thanks, Sue. Thanks, We Can Lead Change, for having us tonight and to talk about what we think is such a critically important topic that affects all of us. Before I kick it over to our speakers, I am gonna show this video, which is is a good introduction and teaser to the conversation that our speakers are gonna have. So, all right, here we go.
Among high-income countries, universal health care is standard, except here in the United States. Why is that? Here's a reason that you may have never heard before. Our failure to pass a national health plan is largely due to America's history of structural racism. In 1945, Democrats were in control of the House, Senate, and the executive, and President Harry Truman decided to push for national health care. That year, 64% of Americans supported a national health insurance plan. Support in the states' rights South, which was heavily Democratic at the time, was even higher than the national average. Seem too good to be true? That's because Truman's proposal would have expanded health coverage through Social Security, which at the time explicitly excluded agricultural and domestic workers. That meant 60% of black men and 80% of black women were not eligible for the benefit. However, the push for national health care coincided at a time when challenges to Jim Crow and discriminatory provisions in federal programs like Social Security were also underway. In 1946, Truman established a Civil Rights Committee, which desegregated the military and banned discriminatory hiring practices in the federal government. Southern elites began to link new proposals coming out of Washington with threats to segregation in education, healthcare, and housing. The possibility that a national health plan would desegregate the healthcare system and institute a significant transfer of wealth from whites to blacks caused Southern support to plummet from 66% in 1945 to only 22% 4 years later. Southern elites were a core constituent of the Democratic Party at the time, and nothing could be passed without them. In 1949, around the time every other wealthy country was moving towards universal health care, the Democratic coalition fractured and Truman's plan in Congress died. In 1964, the NAACP won a landmark Supreme Court case requiring hospitals built with federal funds, which was most of them, to desegregate. A few months later, the Civil Rights Act was passed, reinforcing this mandate. Passage of a true national health plan was still blocked by Southern Democrats in the 60s, since after the Civil Rights Act, this would have meant desegregating the entire healthcare system. So in 1965, the Southern delegation finally came to the table to negotiate the creation of two groundbreaking, yet limited healthcare programs: Medicare, which initially covered only seniors, and Medicaid, a state-run program for certain groups of low-income people. The Dixiecrats ensured that these programs were designed as much as possible around the racial hierarchies in the healthcare system. For example, Medicare is split into two parts. Part A, the part that covers hospital care, requires no premium. Medicare Part B, the part that covers physician care outside of a hospital, does require a premium. Why split Medicare into two parts? Part B was designed this way so that physicians' offices in the South could claim that it was a voluntary insurance program, not a direct government payment, and continued to racially segregate their offices and refuse black patients. And why was Medicaid created as a federally funded but state-administered plan, while Medicare was administered by the federal government? This compromise allowed Southern states to discriminate against low-income people of color in terms of eligibility as well as benefit levels, and this also dramatically slowed the desegregation of nursing homes. While Jim Crow laws no longer exist, the impact of structural racism on our country's healthcare system has been profound. People of color are still overrepresented in states that have poor safety nets and strict Medicaid eligibility requirements, and new waves of immigrants, particularly Latinx, have fallen into these systems of racial inequity created for African Americans. True national health care, like Medicare for All, was blocked by segregationists during the post-war period when the rest of the developed world was establishing healthcare as a right. By the 1970s and 80s, a large healthcare industry and lobby had emerged, making passage of national health care more difficult and likely requiring a massive social movement. It's time to atone for this ugly chapter in our history by building that movement and guaranteeing everyone health care from cradle to grave.
All right, so that kind of just touched on the history of our system and where we're at today, and our speakers are going to expand on that. So without further ado, I'm going to turn it over to KATHRYN KAINTZ and Dr. WINNIE Lin.
For a long time.
Everyone, can you hear me?
Yeah.
Perfect. All right, well, thank you so much to We Can Lead Change for giving us the opportunity to speak tonight. My name is Winnie. As Sue said, I am a pediatrician on the south side of Chicago, and KATHRYN and I are excited to present this presentation on racial inequalities in U.S. healthcare. And it's going to be in roughly 3 parts. We are going to start by talking about our current system, and then go into the history of how we got here, and then end with how we think we should move forward. Jordan, are you able to share your screen? Perfect. And thank you so much to Jordan and the rest of the Illinois Single Payer Coalition for helping put these slides together. We also need to thank Dr. Susan Rogers and Physicians for National Health Program for their inputs as well. And I just want to start with a couple of disclaimers. Number one is that KATHRYN and I don't consider ourselves experts on this topic. We have just kind of put together information that we've learned and think that it's important to share. The other disclaimer on the next slide is that this presentation is meant for educational purposes. Illinois Single Payer Coalition is a 501c3, and as such, we don't endorse or oppose any candidates for public office. Next slide. All right, so let's dive into our current healthcare system. So as you can see right now, our healthcare system is very complex. This diagram kind of illustrates all the different players in the system and the many different arrows, different relationships and connections that they all have, which even for a physician or someone working in the medical field is impossible to completely understand. Right now, we've got people who are covered under multiple plans, people who move between plans frequently. With COVID-19, as you all know, many people have lost their jobs and thus have lost their employer-sponsored health coverage. And so there's a lot of movement between all these different parts, people losing and gaining insurance. And then even for people who stay on the same insurance plan, stay in the same job, each plan could change their rules all the time, and a lot of times the insurance companies do change their rules with very little notice. So if any of you have ever, suddenly gone to the pharmacy and found out that a prescription that you were previously on is no longer covered and you have to change it, or you find out that your doctor is no longer in network, those are all things that are kind of out of our control right now. It's also complicated for hospitals and providers because they have to devote a lot of resources to navigating the system. Hospitals have a lot of administrative waste. There are some that even employ as many billers as they do nurses. And so in the end, it really seems like profits are kind of at the top, which that word is actually at the top of this diagram, and that sometimes we're losing out on what's really important, which is the health of our patients. Next slide. So to talk about the hospital hierarchy, so different insurers do reimburse at different levels. Medicaid pays the lowest, Medicare pays kind of in between, and private insurance, of course, pays the most. And so therefore, hospitals have this perverse incentive to what they call optimize their payer mix, which is really just looking for ways to attract wealthier patients who have private insurance. And it disincentivizes them taking on a large proportion of lower income Medicaid patients, uninsured patients. And so the hospitals that end up with more of those patients, who of course are also more likely to be patients of color, end up being community and public hospitals that are often under-resourced. You can see photos here are of a couple of examples of places that have prioritized the private insurance payers. So North Shore Evanston Hospital is close to home. You can see this like beautiful lobby. There's a grand piano there. And then Mount Sinai in New York actually has executive suites for their VIP or wealthier patients, where they're actually served meals on these like white tablecloth tables. Whereas, you know, the community and public hospitals sometimes don't even have enough nurses or don't have enough PPE, really the basics of what they need to survive. Next slide. And this is a map of Illinois and just some of the examples of how this disadvantage for community and rural hospitals that are taking on more of the Medicaid patients is playing out. So these are some examples of hospitals that have either closed or had to move to nearby wealthier suburbs in order to even stay afloat. This is especially impacted the area where I work, which is on the south side of Chicago. Last year, Jackson Park Hospital closed its labor and delivery unit, which really left a hole in obstetric care on the south side of Chicago. Also in the south suburbs in Blue Island, Metro South closed last year. In Chicago Heights, Franciscan a couple years ago had to move to Olympia Fields, which is a wealthier area. And so what you end up with is a situation where communities of color that are most in need are actively losing their doctors and their hospitals. And so those patients are left with either nowhere to go or having to travel for many miles just to even go to the emergency room. Next slide. So medical bankruptcy, unfortunately, in our wealthiest of nations is a huge problem. A study that came out last year showed that 2/3 of those people who were filing for bankruptcy attributed healthcare costs as a major factor. So either, you know, the cost of their prescriptions, their insurance premiums, their out-of-pocket costs, losing their jobs and thus losing their health insurance due to a medical problem or disability. 2/3 of those total people filing for bankruptcy. And then another interesting point that the study made is that that number didn't actually change significantly before and after the ACA was implemented in 2014. And so we know that the ACA really expanded coverage to a lot of people who were formerly uninsured, but it's still left our system in place where private insurance companies are able to charge high premiums, high deductibles, and thus medical bankruptcy is still as much of a problem as it was even before the ACA was implemented. And compared to people who filed bankruptcy for other reasons, the medical debtors were understandably more likely to forego needed medical attention and medications. And so they're not only dealing with poverty, losing their home, foreclosure, but also this is negatively impacting their health directly. Next slide. So on the other side of it, there are, you know, some people who are doing really well and therefore have extra money to spare in influencing our politics. As you can see here, this is a graph of the top 15 industries that do the most lobbying. And out of the top 15, 5 of those are healthcare related. So the very top is the pharmaceutical industry, followed closely by the insurance industry. So no surprise there. Hospitals and HMOs are also on this list. So a total of $714 million were spent in healthcare lobbying in 2018. Next slide. And this is just a listing of some insurance CEOs' compensation that in 2016. So you can see here these big companies, Cigna, Aetna, Humana, all these big names that we recognize, their CEOs are making so many millions of dollars per year, in contrast to the median earnings of full-time wage and salary workers in 2016, which was $43,000. So, I mean, that is less than any of these CEOs pay per day, let alone pay per year. Next slide. And so you might be thinking to yourself, well, you know, the insurance companies and the pharmaceutical companies are making so much money, and we are spending so much money for healthcare out of our own pockets. So hopefully this results in great healthcare outcomes for the US, but unfortunately that's not the case. So out of the 19 wealthiest countries, we are last in preventing deaths due to treatable conditions. We are 35th in the world in the ranking of mortality that could have been prevented by good medical care. And we are 25th in terms of life expectancy. And on top of that, we have inequities in outcomes. So this picture is a map of part of Chicago. So for those that aren't aware, all the way on the east side there, the Loop, you know, that's downtown, the wealthiest, one of the wealthiest parts of the city. The life expectancy there as of 2017 was 85. But you go just a few stops on the blue line going west, and you're into the predominantly Black neighborhoods of Garfield Park, and the life expectancy dips all the way down to 69. So that's a, you know, a 16-year gap just within a few miles in our city. And obviously that disparity is not caused solely by the healthcare system. There are so many factors that contribute to this. There's poor housing, community violence, community divestment, discriminatory lending practices, all of that kind of working together to create this inequity. But healthcare is one of the main things that we want to think about in terms of, you know, at least for this discussion, how can we improve at least that part of it to start to close this gap. This year, these gaps have been more widely publicized than ever due to COVID-19. There were headlines that came out earlier this spring about some of the inequities that we were seeing in the case rates and the death rates of COVID-19 in Illinois. So the Chicago Reporter in April reported that Black people across Illinois were dying from COVID-19 at 3.4 times the rate of the white population. And then a month later, NBC News reported that in Illinois, Latinos were found to have the highest cases of coronavirus. I actually looked back at the numbers this past weekend to see where we were at now based on the IDPH statistics. And the disparity has kind of gone down somewhat, but is still pretty atrocious. Based on my calculations right now, we're at Black deaths in Illinois being about 2.2 times that of white deaths as a proportion of their population. So still we have a long way to go, and it remains a huge problem. So we are kind of going to go back into history a little bit now that we've set the scene a little bit for how things are right now. The question is, how did we get here? Why is the system the way it is? And spoiler alert, it's got a lot to do with racism and money. Next slide. So in the 1600s, so healthcare under slavery, there was healthcare provided at times as a way to protect the slave owner's labor. Obviously, it wasn't in slave owners' best interest to have their labor dying all the time, so they had to at least care for them somewhat. But for the large part, enslaved families took care of themselves. Slave owners would often try to cure the slaves themselves before sending them to the doctor. And there were slave hospitals and slave cabins with really terrible conditions. In general, Black people were seen as biologically different and inferior by the medical community as well. So even if slaves were able to make it to a hospital, they were still subject to this just absolute racism at the time. And then the Native Americans were not very much better. In the early 1800s, there were treaties that codified the relationship between Native American tribes and the federal government, where in exchange for land, the US government agreed to pay for the health services of Native American tribes. However, Native Americans were interned to reservations where they were at higher risk of disease. They were exposed to diseases that were unfamiliar to them, like smallpox, that really wiped out some entire Native American villages. And when that happened, the government was really more concerned in counting those who died and estimating how many were left and where than actually fixing the problem and delivering quality health care for them. There is also an ugly history in this country of medical exploitation of people of color. So Black people were used for medical teaching and research without consent. One famous example of this was Dr. Marion Sims, who quote unquote practiced gynecological procedures on young Black women, often without their consent and without anesthesia. And probably the most famous example is the Tuskegee syphilis study, where Black men with syphilis were signed up by the US Public Health Service with the promise of free medical care, and then not actually told that they had syphilis, were told that they had bad blood. As a result, a lot of them unknowingly passed the disease on to their wives and children. And even though penicillin became the recommended treatment for syphilis in 1947, another 25 years after that, the study was continuing on without giving the penicillin to these patients because the Public Health Service had wanted to study the natural history and follow these patients to their deaths. And so when you talk about, why is there so much distrust of the medical community from certain populations, you need to look at the history and these just terrible events that happened and still have an impact today. Another atrocity that happened actually up till fairly recently was forced sterilization. So there were multiple groups that were the target of the eugenics movement, like early 1900s up to about the 1970s. Mississippi appendectomies was the sort of euphemism that was used to describe women, largely Black women in the South, who were told that they needed to get their appendix out, but then ended up having hysterectomies done as a way for medical students to practice them. And an estimate was that about 60% of the Black women in just one county were sterilized without their consent. Native American women have also been sterilized in large numbers by the Indian Health Service. Many of these cases were not documented, but it's believed to be more than 24% of Native American women were sterilized in the 1970s. And then Latino, both men and women, were sterilized in large numbers in California and Puerto Rico at around that same time. And so some of you may have heard about what's currently going on in the news, where a whistleblower at an ICE detention center in Georgia revealed that there was an obstetrician there that was doing hysterectomies without consent. And so, that really has a lot of precedent in our history. And unfortunately, it seems like some of this is still going on today. So shifting a little bit to the hospital system. So in the 1800s to the 1930s, hospitals were mostly private and nonprofit. So different ethnic groups were caring for their own ethnic group. There were Irish Catholics with hospitals for Irish Catholics, Russian Jews with hospitals for Russian Jews. And since these hospitals were private, those providers could see or not see whoever they wanted. And so the people that were left out of that system were the quote unquote non-deserving poor, which were usually Black people. And they were left to go to county facilities, which had much worse conditions. And then after the Civil War, there was kind of similar to the situation under slavery, where there's this ambivalence from white leaders about providing care to Black people because they wanted them to be healthy enough to do labor, but were also fearful of a free and healthy Black race and worried about diseases spreading to their communities. So with all of those kind of opposing interests, there was an attempt to provide health care to the newly freed slaves, which was called the Freedmen's Bureau of 1865. That program deployed 120 doctors to the South and opened about 40 hospitals, but those hospitals were severely understaffed, short of equipment, and the government never really came in to save them. So after only 7 years, the Freedmen's Bureau just ended. And now I'll turn it over to KATHRYN.
Okay, thank you. So we jumping significantly in the future a little bit here to the 1930s. And this is when we really start to see the emergence of the private health insurance system and its connection to our employers. The employer health insurance connection was solidified during World War II when employers couldn't offer employees better wages due to frozen salaries, but they could offer tax-free health insurance benefits. So this continued, and by 1950, 50% of the population had employee-sponsored coverage, which definitely laid the framework for our current system, which, if you think about it, doesn't make a lot of sense why our employers are really associated or connected or responsible for our healthcare in any way. So, and of course, this system was, once again, inherently racist, as Black people were often denied the opportunity to employment that offered these employer health insurance benefits. Next slide. I'm gonna breeze through these next few slides because the video that we watched beforehand really very eloquently explained this. But as mentioned, in the 40s, President Harry Truman saw an opportunity to introduce a national health service plan like most of the developed world. Again, like the video mentioned, it was a popular sentiment until it became synonymous with civil rights laws being passed. And again, it was another opportunity for universal health care squandered due to the blatant racism in the country. Next question. But eventually, as again the video mentioned, we now at that point have a robust and growing employer-sponsored healthcare program, but there's glaring gaps in coverage for the poor, the elderly, and the disabled who either are not able to work or find work in employers that provided the employer-sponsored insurance programs. So it wasn't until the 1960s that we even began to address these gaps when President Johnson was able to pass the Medicare bill in 1965, which includes both Medicare and Medicaid as we know it today. And although this was not a solution to cover everyone, especially again, Black people who were not, elderly or disabled, who worked but not at jobs that offered the employer-based insurance, it did have one major positive outcome, which was in combination with the Civil Rights Act passed the year before, the federal government required all hospitals receiving these more substantial Medicare reimbursements to desegregate. So this led to virtually thousands of hospitals desegregating overnight. But again, as the video eloquently described, there was definitely racism baked into this bill. So as it mentioned, Medicaid as a state regulated program was and continues to be affected by discriminatory eligibility requirements, while racist healthcare providers could continue segregating their practices and refusing care to those they did not want to serve by pointing to the extra costs associated with Medicare Part B as proof that it was quote unquote voluntary insurance and not, that did not fall under the Civil Rights Act. Okay, so unfortunately, we have not made much significant or history-altering reforms to our healthcare system since the 60s and the passage of the Medicare bill. And as we just explained, there's racism embedded in both programs which may look a little different, but definitely continues to this day. But what definitely happened over the preceding decades is that the health insurance industry moved toward a for-profit model and to capitalize on people's desire for health security. And in 1994, that's really when it started to ramp up, when then Blue Cross allowed its franchises to become for-profit. And this led to the heinous, price gouging and financial waste that Dr. Lin reviewed earlier in the presentation, and the massively powerful health insurance lobby addressed in the video, and which continues to be a major barrier to any change today. But what I'd love to do is now share a solution and discuss, what a single-payer healthcare system could look like in our country. Next slide. So first, the basics, like what is single-payer healthcare coverage? It's simple, and that's why it works. It covers everyone from birth to death, everyone. It's comprehensive coverage, so it includes medical coverage, preventative care, dental, vision, hearing, long-term care, prescriptions, mental health, and reproductive care. And I always like to list this out when giving this presentation, because if any of these are missing, then it is not truly universal healthcare. So each one of these is important. There's no cost sharing, so there's no co-payments, no premiums, and no deductibles. And it's paid for by one national payer, but the care provided is still provided by private institutions. This is a big fear-mongering tactic that anti-single payer lobbyists like to use, that the government will decide what care you get. And that is absolutely not true in any single payer system. The government controls the reimbursement, but the providers control the care. And at the moment, we have the opposite, where the insurance companies are really controlling what care our healthcare providers can provide. So it's just a great infographic, and I love it in contrast with the one Dr. Lin showed at the beginning of the presentation, that shows that like you as a resident of the country or in the country can go to your doctor when you're sick. You can go to any doctor you want because there are no networks. There's no random non-clinical force telling you that you have to go to specific doctors. The doctor will treat you. They'll order any exams, prescriptions they deem appropriate. You go home, live out your life, get better. They bill Medicare, and they receive payment from Medicare within 2 to 4 weeks. Like I said, you go home and you do not receive a bill because this is already paid for. And some benefits. So as Dr. Lin talked about earlier, medical bankruptcies are a huge problem. Because this is universal and there are no costs, you don't receive a bill. Therefore, the problem of medical bankruptcies disappears. Healthcare is not tied to employment. So right now, if all of the people who are losing their employment would not have to worry about where their health insurance is going to come from. It lifts the burden of healthcare from employers and local municipalities when it comes to Medicaid, which I think is a huge under-discussed point. Why should employers have to be the ones responsible for providing care? Of course, you have the freedom to get care, and it's just inherently more equitable when everyone has access. And of course, especially in a presentation when we're focusing on racial justice, we are in no way suggesting that a single-payer healthcare system will solve racism in our country. It can't improve all social determinants of health, like housing, food access, and safety, and it certainly won't eliminate racial bias in medicine overnight, which is a problem that no healthcare provider can ignore. But what it can do is give everyone the ability to access care, no matter what their job, income, age, or marital status. And of course, eliminate the incentive of providers and hospitals to cater to the wealthy literally in order to stay open and survive. Okay. So this is a great slide. I love this slide because it shows how in 3 different examples that does provide kind of a smaller scale, single universal healthcare system, how racial disparities nearly disappear in each one. So if you're on dialysis, you are on Medicare, so you are getting, or the dialysis is being reimbursed or paid for through Medicare. So whether you're white or black, and if you're on dialysis, it's reimbursed the same ways. In the VA system, of course, access doesn't depend on race, you just have to be a veteran. And of course, in Medicare, as we know it right now, if you're above 65, you do qualify for Medicare. So again, it does not depend on race. So we see some very interesting outcomes. In the dialysis population, Blacks live longer than whites, actually. In the VA, Blacks also live longer than whites. And in the Medicare population, mortality rates, even in an older, sicker population, just biologically, mortality rates quickly match across races. Okay, so of course, in any single payer conversation, there are always going to be people and politicians advocating for quote unquote less drastic change or incremental change. And we heard this during the Democratic presidential primaries again and again. So over the next several slides, I want to discuss how these types of proposals really fail to address many of the problems we've discussed throughout this presentation. And we use the term public option, but this is a very broad term that would include initiatives and bills even like the Affordable Care Act. There's also many, many different public options that, for instance, each Democratic presidential candidate had a different one. So it's a kind of a catch-all term for smaller incremental changes. So first, as we've discussed, there are dramatic inequities between whites and people of color, and people of color are still more likely to be uninsured or underinsured, and also more likely to die from preventable and treatable diseases. So under a public option, we still would not have universal access. And unfortunately, you may have seen in the most recent presidential debate, Vice President Biden admitting that his idea of a public option would actually only cover people who are Medicaid eligible. So even in how some people may see as more progressive politics, this is still not a universal plan. And it's in many instances, like we've seen with the Affordable Care Act, these incremental plans still include very high deductibles, high costs. And so you might be technically insured, but it's still going to discourage or dissuade one from seeking care for the reasons of they don't want to end up in medical bankruptcy. And as Dr. Lin pointed out earlier, the Affordable Care Act and incremental plans like it, do very little to solve this medical bankruptcy problem. Next slide. So another problem we talked about earlier was fewer healthcare facilities, and the existing facilities are under-resourced and are closing or in danger of closing. And these plans do nothing to equalize funding or direct resources to underfunded facilities like those that have closed or are closing. And a single payer system would fund hospitals through global budgets based on community needs and not on profits. So all providers and hospitals are reimbursed based on the needs of their communities, which would not require institutions to seek out patients just to survive. Seek out patients who will bring in more income just to survive. Next slide. And the third example is, racism is inherently embedded in our healthcare delivery system. A public option would just be another piece of the patchwork, fragmented health system that we currently have. It would provide no resources or requirements for research or education to combat racial bias in the funding and delivery of care. And under a single payer option, we can collect universal data on inequities throughout the national healthcare system, which would inform our racial bias research, and then therefore standardizing essential training and education for all healthcare professionals. So I just wanted to, put these two graphics in contrast. So in a public option or the Affordable Care Act or some kind of baby step policy would just add more chaos to the big mess of our already chaotic healthcare system, where a single payer system would provide universal care to everyone and allow hospitals and providers to focus on providing high quality care and also being reimbursed at an equal and fair rate. So just finally, our final slide. So the establishment of Medicare and Medicaid in 1965, and of course the Civil Rights Act in 1964 was transformative in desegregating the nation's healthcare system for patients and providers and improving access to care. And we can definitely not deny that. But what is also clear is that there is immense change that is still needed, and we need to continue improving access to care and just start to bridge the racial inequities that still exist in our system. If Medicare, as flawed as it is and flawed as it was and it still is, created the immense change that it did, we just want to leave you with the question of what could Medicare for all or a single payer healthcare system do to improve the racial health inequities of today? So, thank you.
Thanks, Catherine. Thanks, Dr. Lynn. Sue, how are we doing on time? Do we have time for that video?
Yes, definitely.
Okay, great. I will do that. Okay, maybe we're not going to try that video. I'll try it again in a little bit and see if it works. But that was a nice a wrap-up video and for us to watch. But I'm going to go ahead and transition into questions and answers. So if you, I don't think there's any questions yet in the chat, but if you have any questions, please feel free to write it in the chat box. You can also raise your hand on the Zoom call, and you can do that if you're not familiar by going to the bottom of your screen and clicking participants. And then you should see a white box pop up to the right, and there should be a button that says raise hand, and then I'll be able to see that.
I just want to cut in. I'm so sorry. I have to run a little early than the end time, but I just wanted to say thank you so much for giving us the opportunity to present. And Jordan was nice enough to take over my portion of the Q&A. Thank you.
Thank you.
Bye, Catherine. Okay, so it looks like Sue has a question. So Sue, I think you're unmuted, so go ahead.
Yeah, the slide that talked about how single payer would take a large burden off of municipalities and employers. I have taken that in my mind a step further, and I'm wondering, wouldn't it also take a large burden off of the state pension systems that are utilizing private health insurance?
I would say the short answer to that is yes. I don't know what the exact numbers are in regards to the pensions. I do know that a quarter of our state budget goes to Medicaid. And Medicaid changed in, I think the law changed in 2011 to allow private companies to manage Medicaid. And now pretty much everybody, unless you're on Medicare, if you're on Medicaid, you have to be contracted through a private insurance company. So what our state is doing is we're giving money on an annual basis to these private companies who are covering the poor and sick in our state. And they make money off of the money that the state gives them. They wouldn't be in this business if they weren't making money. And so they're pocketing that money and then giving subpar care to our poorest and our sickest in this state. And that's a quarter of our state budget, which is just mind blowing to me. And, you know, if we had Medicare for all, that expense would go away entirely. So Winnie, I don't know if you know more about the numbers for the pensions for state employees.
Yeah, I don't know that number specifically, and I would echo everything you say. I mean, right now, you know, the way our government finances programs is very different for federal versus state. So for states, you know, they really have to budget like a kitchen table kind of budget. They have a set amount of money from taxpayers and some from the federal government, and so they're constrained in that way. And so whenever anyone is bringing Medicaid up for a vote, you know, that's always kind of like the first thing that people want to cut because it does strain state budgets a lot. Whereas Medicare for all or a single payer national system would be funded federally, which, you know, the federal government has the power of the purse. We are able to spend, you know, how many billions and trillions of dollars on corporate tax breaks and the military. And so they are able to spend large amounts of money, as they've demonstrated this year, you know, without leading to inflation, which is, you know, the main thing that you worry about with excessive government spending. And so there would be much more ability to pay for a national single payer system than our current system.
And so I'm going to look into that because that's a good question about what that figure actually is. And then it looks like there's a question in the chat. Why do we talk that Medicare for all would save us money in taxes and public option would raise private taxes? Do you want to take that, Dr. Lynn?
I'm not sure I understand the question. What are private taxes?
Sorry, can I say I'm told I'm the one that said the question?
Sure.
I'm talking about, so what I mean is by public taxes is what you already paid to like the state government and all that stuff. And the private tax, that's your co-pays, your premiums, your deductibles, all that stuff. And it's basically, what I'm trying to say is that Medicare for all is essentially a small business tax cut because you're removing a lot of the overhead. And with the public option, you're essentially paying for a two-tiered system. So it's just that it doesn't have anything to do with costs. He said only people benefit from Medicare, and which means that costs are still going to go up. This is going to be especially your out-of-pocket costs because the corporations will find a way to subsidize that kind of money, because even with a public option, even if Biden wants to do his plan, which I highly doubt, his thing is to eliminate co-pays, but there's still going to be the public options, and which means they're just going to raise those prices and not cover as much.
Yeah, I think you answered the question for us.
Yeah.
So yeah, I mean, you're exactly right. So Medicare for all is going to save money because we're going to get rid of this huge sector of the healthcare industry that actually doesn't pay for healthcare. So more than half of Americans are covered under employer-sponsored health insurance or private insurance, but they only pay for less than a third of actual overall healthcare costs. 2/3 of healthcare is actually already paid by the federal government and the state government. And so with Medicare for all, we're kicking out this sector of the healthcare industry that is actually, you know, really wasteful and, you know, spends a lot of money that actually doesn't go towards healthcare. So the overall money that we're going to be spending, yes, the government will be spending a little bit more for healthcare, but overall we're going to be spending less than we currently do, which is why we're going to have savings. And yes, there might be some taxes that come with that, but that's going to take away all of your co-payments, premiums, and deductibles. And then with, you know, the public option, all that, yes, that's probably going to help some people, but all that does is add, it's a Band-Aid on a bullet wound. It's just one extra piece of infrastructure that we're tapping on to this already mess of an infrastructure. And yes, it might help some people, but it's going to add another layer of bureaucracy and another layer of waste. So a public option is actually, when you look at the studies, it costs more than the single payer plans. Dr. Lynn, did you want to add anything?
No, I think that was perfect. Yeah, I mean, there was a Yale study that was published in the Lancet just earlier this year that where they analyzed the costs to the total, like the country as a whole in a single payer system versus our current system, and it did show that we would ultimately be saving money over time.
If I may ask, sorry
Yeah.
to interrupt, if I may ask just one more question. And this is what, I don't know if you can answer this, but how come Biden hasn't told us how much the public option costs? It seems that like everyone who supports single payer has to tell us how much it costs, but Biden can literally say the public option, and he doesn't tell us how it costs or how he's going to pay for it or anything like that. Do you have any answer to that, or do you even know how much it would cost? Because I've done my own math, and it seems like it would probably be about like $7 billion. Well, I know that the current system is about like what, 35 trillion. I mean, 35, sorry, about 5 to 7 trillion more. It's like 35 trillion. Medicare for all will be 32 trillion, and the public option will be like 40 trillion. That's just I'm not a healthcare person, but do you know like how much it would cost and how he's even going to pay for it?
No, I don't think he's answering those questions. Honestly, you know, he made the public option a part of his platform during the primaries, but I think he's backed away from it. I don't think he's making it a strong part of his platform. And I don't think that, you know, his opponent is asking him those questions. And I'm not sure in the primaries if Bernie and Warren were asking, I'm sure they tried to ask him how much a public option would cost. I doubt that Biden had the numbers. I'm sure that those numbers are out there. I know the studies have been done. I can't rattle off those numbers for you offhand, but I do know that it's more expensive than a single payer plan. And it's, you know, to think our plan is already 20% of our current system is already 20% of our economy. You know, how can it get much more expensive?
Thank you. Sorry, I gotta go, but it was a pleasure meeting everybody. Sorry for taking so long.
Oh no, you're fine. Thank you. Is it Tolu?
Yes, ma'am. And have a good night, and everyone, please stay safe.
Thanks, you as well. I'm being told that Ellen has a question. Ellen, I'm going to.
I just want to clarify. I know that this was about single payer, but I am very interested in the issue of racism in healthcare. And my understanding is maternal outcomes are much worse for pregnant women of color. And I think that we have to acknowledge that the system is not only racist economically, but that there are such implicit biases that we do not give first-class care to people who deserve it because we have those blindnesses. Just wanted to acknowledge that as an additional layer that still needs attention that single payer won't fix.
Yeah, I'm glad you brought that up. So, I mean, the numbers as of a couple years ago, I'm not sure if they've been updated since then, is that Black maternal mortality is about 3 times greater than white maternal mortality. And there have been studies actually of newborn infant survival for Black babies, like when they have Black doctors versus white doctors taking care of them. And their survival is much better when they have Black physicians taking care of them. And so that is definitely something that, you know, single payer is not directly addressing that problem. But that's another entire problem in itself that definitely needs to be addressed.
Yeah, and Ellen, we usually say that single payer is the first step into getting a healthcare system that prioritizes people. You know, it's not going to solve everything, but it's going to do this amazing thing of getting people through the door and getting people, you know, that huge barrier of cost. It's going to get eliminated by single payer, and then we can go from there.
Ellen, you're turning me into a believer about that.
Thanks, Ellen. I did see a question earlier from Gina about what is the way forward. Of course, we would love to have single payer enacted, and depending on who wins the election, you know, we'll do a good push forward in the first 100 days and see if by any miracle that's possible. In the meantime, what we're working on as an organization is what we're calling Patients Over Profits campaign. So we are working on trying to get our two senators, Durbin and Duckworth, to take the Patients Over Profits pledge, which says that they'll stop taking money from corporate healthcare, being private insurance and pharmaceuticals. And so we're not even doing the step of asking them to support the legislation that we need. We're just saying, we know that you take this money that is dirty, and we know that it influences how you vote and the policies that you stand for. And, you know, that's why when the pandemic went down, Senator Durbin, instead of advocating for a mass expansion in healthcare, he advocated for COBRA subsidies. And, you know, that what that would do is give, you know, that will help some people, but also it gives more and more business to private insurance. So we know that there's this toxic relationship, and we need to address that. And so we have this really lofty goal of getting the senators to sign this pledge. And so we are working hard on that. We have a petition that folks can sign that I'm going to link here. We're also having a call a week from today, and we're going to talk about the campaign. We've been doing it for a few months. We're going to talk about what we've done so far, and you know, really make our plans for the next couple months on how we want to continue and escalate the campaign. So I'm also going to send a link to that meeting as well. So if folks want to get involved with this Patients Over Profits campaign and try to move towards healthcare justice, you can certainly do that. And Mary's hand is up. So Mary, I'm gonna post those links, but first I'm gonna unmute Mary so she can talk.
Hi, as a senior citizen, I am constantly being deluged with ads for Medicare Advantage. And I even go to the hospital to get tests, and there are ads everywhere in the hospital for Medicare Advantage. And it really pisses me off, because most seniors have no idea that these are invitations to privatize Medicare and to let the insurance companies make money off of Medicare, and to drain money out of Medicare. And I wonder how we can fight that, besides just as individuals not buying into it. How can we push back against it? Thank you.
Thanks, Mary. Dr. Lynn, you want to start?
Yeah, I mean, there are different levels of advocacy, right? So you touched on one, which is just the individual, you know, not purchasing certain products. And then there's advocacy, which is, I think, why a lot of you are here and involved in this organization, where we are trying to do grassroots organizing around these issues. There's, you know, political lobbying, voting, all of that. And so, you know, I think it's just a matter of kind of picking what level of involvement you want to be at. The Illinois Single Payer Illinois Single Payer Coalition, we are kind of focusing on, you know, going to the root of why politicians either actively pursue or allow things to happen in terms of insurance companies getting their way, which is the influence of money in politics. And that's what this Patients Over Profits campaign is about.
Yeah, Mary, I would say that I don't have a good answer for that. That's, a huge part of the problem because, Medicare is a really great program, and compared to its counterparts, it's really sustainable, it's cheap, it's efficient, it covers a fair amount, but it's being co-opted right now, just as Medicaid is, by these private insurance companies. And Medicare Advantage is a scam. It's, they sell, cheaper premiums. And then when people get sick, they realize that the plans don't cover everything. And it's a total scam. And it's, I think it's tainting the name of Medicare.
Right.
And as an organization, that's kind of, that's one reason why, we stick to the Illinois single payer language and not the Medicare for all language. Because we realize that it's trying to be co-opted. But yeah, I would say there's not an easy answer. It's a lot of education like this and setting the record straight to folks. So I don't see any other questions. And I know, Sue, you wanted to wrap up, I think 10 after. So I think I'll hand it over to Sue.
Well, we want to thank everyone for taking time to attend tonight's presentation. Many thanks to Illinois single payer presenters, Jordan Centers, KATHRYN, KAINTZ, and Dr. Winnie Lin for this informative presentation on healthcare justice and racial inequities. I think we all have learned a lot, even those of us who've been to several presentations like this. It gives us points to share and to research and to just move us farther along in this giant and frightening conversation that's happening in our country right now about our access to healthcare. A quick personal thank you to Jackie Degatano for partnering with me to bring this important topic to our Weekly Change educational series. Her attention to detail and knowledgeable enthusiasm is priceless. Thank you, Jackie. And a reminder that tonight's Zoom meeting is being recorded and will be emailed to each of you as well as posted on Facebook. You will be able to share it with others who were unable to attend in person. So thank you so much and have a great night.